Welcome to the Health Trip Podcast. My name is Jill Foose. I'm a functional medicine and integrative nutrition health coach. I created this podcast to bring you along as we travel down intriguing, science-packed roads, debunking old medical paradigms and perusing new innovative therapies and modalities with the finest functional medicine doctors, practitioners, and like-minded biohackers while living our best life. Enjoy the show. Hi, everyone. Welcome back to another episode on the Health Trip Podcast. According to the CDC, over 60 million women in the United States are living with some form of heart disease. From the American Heart Association, more than 1 in 3 women is living with some form of heart disease. Heart disease and stroke cause 1 in 3 deaths among women each year, more than all cancers combined. According to the British Heart Association, after menopause, your cholesterol levels can go up, increasing your risk of heart attack and stroke. Your body cannot control sugar levels as well, and this can increase your risk of diabetes, high blood pressure, and weight gain, which we all know as metabolic syndrome. Women have historically been studied less regarding heart disease risk, although that is changing with some very impressive women cardiologists. As women move through the menopause transition, it has been shown that as estrogen levels decline, a woman's CVD risk may increase. Estrogen is heart protective, and more is being done to educate and screen women to see if they are good candidates for MHT or menopause hormone therapy. But still, so many women remain confused and overwhelmed by the barrage of information on the internet with misinformation or lack of information provided by their doctors and their current fear-based understanding of taking MHT and getting breast cancer. It's February, which is National Heart Disease Month, and I have a very special guest joining me who will bring some clarity on the topic of midlife women's health and heart disease risk. Dr. Michael Davidson is board certified in internal medicine, cardiology, and clinical lipidology. He's a professor of medicine, director of the lipid clinic at the University of Chicago Pritzker School of Medicine, and serves as the chief executive officer of New Amsterdam Pharma. Dr. Davidson earned his medical degree from the Ohio State University College of Medicine and completed his residency and fellowship in cardiology at Rush University Medical Center in Chicago. An active researcher, Dr. Davidson's clinical research background encompasses pharmaceutical and nutritional clinical trials. His extensive research on statins, novel lipid-lowering drugs, and non-pharmacologic risk factor reduction have established him as a world opinion leader. He's a prolific author and lecturer on lipid disorders, nutrition, and atherosclerosis, and has coordinated more than 1,000 clinical trials in areas of preventive cardiology, published more than 250 articles for leading medical journals, and has written 3 books on lipidology. He has been named one of the best doctors in America for the past 15 years and was named Father of the Year by the American Diabetes Association in 2010. Ladies, we are in very good hands. Here's a medical disclaimer before we start. By listening to this podcast, you agree not to use this podcast as medical advice or to make any lifestyle changes to treat any medical condition in yourself or others. Consult your own physician for any medical issues that you may be having. This entire disclaimer also applies to any of my guests on my podcast. So sit back, open your mind, and let's dive into heart health for women. Hi, Dr. Davidson. Welcome to the Health Trip Podcast.
Hi, Jill. Great to be here.
Yeah, thank you so much. I'm really excited to have you here. Of course, it's February, so it's National Heart Health Month. And a lot of women listening are feeling really confused about what they're supposed to be doing for themselves. How should they eat? What should they ask for in terms of labs from their doctor? Who do they go see? All the things. But before we dive into all the nitty-gritty, how did you become a preventive cardiologist, and how does that differ from a regular cardiologist?
Sure. Well, for me, it's all personal. My father died at age 47 of a myocardial infarction, a heart attack. I was 16, and at that time, I decided I was already thought about being a doctor. It kind of runs in my family. I'm one of 6 kids, and 5 went on to become physicians. So I decided then that I was going to be a cardiologist. Uh, and and in medical school, I started doing research on cholesterol and did the first niacin trials at Ohio State, where I was in medical school. And then I went on to residency and training in Chicago at Rush. And I started doing work on omega-3 fatty acids, fish oils, and got very excited about lipid metabolism, new cholesterol therapies. I was on the forefront of the early, statin trials way back when. And so I decided that I'd make that a career. And it was unusual at the time to be a preventive cardiologist. But when I first went into practice in 1986, I specifically dedicated my entire practice to prevention. So we set up a nutrition, psychologist, exercise physiologist, all aspects of prevention was part of our program. Of course, I also got very consumed in clinical trials and started doing a lot of research. And so that kind of was all part of the whole kind of milieu of developing new therapies. And so that became the preventive cardiology specialty, which is still, evolving, but right now we're a relatively small percent of the total practicing cardiologists in the United States.
Yeah, I would agree because when I bring up to my clients, maybe we should start building your healthcare team and include a preventive cardiologist. You people are not easy to find.
There's a spectrum of what preventive cardiology means. I mean, one is lipid specialist, that's which is part of it, but also a lot of other aspects of it: exercise physiologist, hypertension, other risk factor
Right.
management, imaging, how to better use risk stratification with imaging. So it's all part of the whole preventive cardiology kind of world. But it is a niche, but because most cardiologists try to do some aspect of prevention, or at least they should, and they kind of know the basics. But when it comes to really understanding complicated cases in particular, you really should reach out to a preventive cardiologist.
I think what might be confusing is most people have an internist, right? And so when you go, your internist is usually your first stop. And of course, they gather your blood work for your annual appointment and they look at that standard lipid profile, which is something we're going to dive into on this podcast. And then sometimes it just doesn't go beyond there, even though there might be signs and symptoms of heart disease risk for someone. And, heart disease is still the number one killer for both men and women. And for the sake of this podcast, talking about midlife women, why is that still there? Like, do we bring to the table unique risk factors that affect us in a different way?
I think the, the most challenging part is a little bit historical. Um, the history is very unfortunate, and it's very male biased. There was a famous, kind of, the first guidelines that came out were basically recommending lipid therapy only for older men. And so it was
Yeah.
the joke was a bunch of old men got together and decided that only old men should get treated for high cholesterol. That goes back to the 80s, even then. And it was this kind of belief that women, were protected from heart disease, and that is partially true, but it's changing a lot most recently. But it's about a 10-year lag between, when women on average get heart disease versus when men get heart disease. But that can be quite variable, and a lot of factors go into that we can talk about. But in general, women when they get heart disease, tend to have more severe heart disease, and they tend to die more rapidly of heart disease once they get heart disease. So in particular, prevention is even more important for women than it is for men, because once they already have heart disease, the prognosis is a lot worse.
And so, what are some of those risk factors that are unique to us?
Well, for women in particular, it's lipids, cholesterol, but also uh, perhaps even more so the triglyceride elevation. Low HDL has always been more prominent in women than it is in men. So those are the two lipid factors. And also body fat. If women who tend to have the the apple versus the pear, are more prone to heart disease. So all those things are things that you should look at more importantly, but also there are many important genetic factors in women like high Lp(a), family history that in particular are very potent risk factors for women that should be screened for. And I think what we rely on data from 30, 40 years ago when women had this, protection, but now with the whole, menopause kind of hormone therapy
Yeah.
controversy, I think we're seeing heart disease rates that are going up, and there's been improvement in male survival and reduction, but women less so than men in particular. So there's a big disparity between, what we saw in men getting less heart disease is not so true for women getting less heart disease over the last 20 years.
So some of the things women are hearing on the internet are in relation to menopause is that estrogen, for example, is cardioprotective. And so as we move through the transition of menopause and our estrogen levels go down, especially for those who decide not to take menopause hormone therapy, that this could be a risk factor. Also, pregnancies. How many pregnancies did you have? Things like hot flashing, right? So flashing and um, a lot of doctors are saying the more flashing that a woman does, even though she may or go on medication for that, that's still a risk factor, or the early onset of menopause and menses. What are your thoughts on all of that?
Well, so basically, yes. I mean, the earlier you start menopause, for women, for example, who have premature ovarian failure, their risk is higher. Women who start menopause earlier than women who start later are at higher risk for heart disease. Um, Women who, as you mentioned, who have more severe postmenopausal vasomotor symptoms are at increased risk for heart disease. So, so there lies, maybe hormone therapy would be protective. However, there's been two famous studies, which I was part of, both of them, where women who got hormone therapy postmenopausally, both Premarin and Premarin plus progesterone, failed to show a benefit on cardiovascular disease. One was a Women's Health Initiative, which is a primary
Yeah.
prevention trial. The other was the HERS trial, which was a secondary prevention trial. Now, the problem for both studies, in my view, is that they both were starting women on hormone therapy about 10 years after
Yeah.
menopause. And so that impact of that is hard to gauge, but it doesn't fit what you would normally do for women, post-menopause. You would start with menopause. And if you look at the animal data, which is where it started with in many respects, other than the epidemiology, was that if you use hormone therapy in primates during the early phase of menopause, you do in fact reduce atherosclerosis, which is the precursor for heart disease. So in general, I try to be evidence-based and make sure that it's really important. It's really shared decision making. But in general, I like to encourage women to use hormone therapy, postmenopausally, especially if they have symptoms. Of course, that makes all the difference in the world. But I still believe there's benefits there, although, again, from the big trials that were done, we don't have a good answer. And in
Yeah.
fact, I don't think we are going to have an answer, to be honest. It's going to have to be, based on everyone's individual review with their own doctor about what the right decision is for them.
Yeah. So, should a cardiologist, if they're seeing someone, even an internist, if they're seeing a midlife woman and this woman comes in and she's complaining about hot flashes and other menopausal symptoms, and he recognizes it on her standard lipid panel, perhaps she has raised triglycerides and LDLs, should that doctor say to the woman, let's get you referred to someone who's a menopause specialist so you can at least get the education and be a well-informed patient who can then make a better choice for yourself? Because that
Uh,
doesn't happen most of the
yeah,
time.
I think that's great advice. I have to say, though, the spectrum of expert views on this can be quite
Yeah.
confusing. And I don't mean to demean it, because it's really challenging sometimes to get the right answer. I wish it was a clear cut. It's one of those things in medicine, which is not, there's no clear cut answer about what to do. And you might get opinions that are, quite different from each other. So just to
Yep.
keep that in mind. But I would say, in my opinion, I think women should not be afraid to use hormone therapy. I do think there might be healthier ways to do it. They should talk with a menopause expert who would know that, what the right hormone therapy is for a specific woman for whatever reason. I think,
Right.
the bioidenticals or the transdermal or the patches. There's all different options to consider for what would be best for a particular woman. And so I think it is complicated, but I would say get the best advice you can. But especially if you're symptomatic, you definitely
Yeah.
shouldn't be afraid to use hormone therapy if necessary to alleviate the symptoms.
Yeah. Well, let's dive into a standard lipid panel because this is what most women are seeing. And by the way, there are many women who don't go to the doctor. And I also think that's another reason why that number of women dying of heart disease is so high because we often tend to take care of all of those around ourselves, but not ourselves. So if you've not been to the doctor and you're listening to this, get there. So a basic lipid panel. This includes things like total cholesterol, LDL, HDL, triglycerides, and a non-HDL. And a woman goes in, she's more of a passive patient, and she sees her results. Her doctor says, good here, not so good here. Take us on a tour of this standard panel, and then we're going to go into a more comprehensive look as well. What do women need to know about this standard panel if this is all they're getting?
Right. So the most important thing is they'll get a total cholesterol, which is not helpful at all for a woman. Total cholesterol is meaningless. And so then you get the LDL, which is the low density lipoprotein, which is calculated from the total minus the HDL with a triglyceride divided by 5. It's a formula. If you get an LDL that's calculated, that's the most important number to look at. And that, ideally, should be as low as possible for cardiovascular risk. The lower the better for
Which,
LDL.
what number would that be?
Well, it depends. I mean, ideally below 100, but depending on other factors, it should be lower. But also it can be higher than that and not be so bad. It may not be a bad thing. So it's really important to look at the other aspects of the lipid profile. In particular, the other two that you get is HDL and triglycerides. So HDL is also controversial, and it's also a misunderstanding about HDL. Years ago, the Framingham Heart Study, showed that when you looked at total cholesterol divided by HDL, the ratio, that
Hmm.
was your best predictor of risk, or the LDL divided by your HDL was your best predictor of risk. That went out of favor because LDL was established as the causal factor for heart disease. LDL is what gets stuck in the arteries and clogs up the arteries and leads to the plaque formation. HDL is thought to be the cholesterol that removes the plaque cholesterol and takes it back to the liver to be cleared. However, it's a lot more difficult to explain that. It's not what we always thought it would be. So HDL, typically is higher the better. It's protective, but there are situations where high HDL can be not protective or even harmful. And so we've learned not to depend so much on the HDL being high as being protective these
Mm.
days. You have to kind of look at the total picture. So if HDL is above 60, which is generally good, and LDL, could be higher, and as long as there's no family history, you're usually in pretty low risk overall, as long as other factors are not present, like high blood pressure or smoking. In particular, family history is important, and
Yeah.
so we want to understand the other risk factor or diabetes. Those are the things that you think about. But when you have a high HDL, you should not necessarily disregard a high LDL, and that's, I think, one of the things that gets into trouble for women. Many doctors have that misunderstanding that as a lipid specialist, I'm often received feedback. A woman says, my doctor said, don't worry about my high LDL because my HDL is also high, and that's protective. It's not always true. It can be true, but it's not always true. And so it's important to really look at the LDL primarily. Now, for women in particular, I mentioned triglycerides and low HDL are very important factors. So you have a high triglyceride above 100 is considered a little high, above 150 is high, above 200 is certainly high. Fasting, because triglycerides can be very much impacted by what you've eaten recently, and so you should be fasting. But if
Yep.
triglycerides are above 200, it's a very powerful risk factor for women. If a woman, if anything, the data would suggest that might be one of the most important risk factors for premature heart disease in women was triglycerides that are elevated. But the truth of the matter is what triglyceride elevation means typically is that you have a low HDL or dysfunctional HDL, the protective cholesterol or potentially protective, but also more importantly, you have a lot more LDL particles. You have a lot more, your LDL cholesterol that you have is not what you really think it is. It's actually a lot higher. You have a lot more particles, and these particles tend to be small and dense particles, which are much more likely to clog up the arteries. So we get the standard lipid profile. If you have, a high LDL and a high HDL, you got to understand, the balance there. But if you have a high LDL and a high triglyceride and low HDL, that's a bad combination where you really need to dive in more carefully into what to do next.
So, if a midlife woman has an optimal looking standard lipid panel, is that good enough? Should she stop there, or should she continue to pursue a more comprehensive panel, which we're going to dive into with her doctor?
I think most importantly is family history and
Yep.
other risk factors. And so if that woman has longevity, no premature heart disease in the family, and a really good lipid profile, LDL below 100, HDL above 60, triglycerides below 100, no other risk factors, no diabetes, no hypertension, doesn't smoke. They're almost always okay at that point. But there is one thing missing called LP little a, which you would not get unless you did the more advanced lipid testing. But that's typically in the setting of a family history. And so without any family history, it would be unusual to have that be elevated as a single factor that you want to still consider. So in the absence of any family history and an excellent lipid profile and other risk factors, I think for most women, that's going to be fine. That's really fine, unless they really want to dive in just to be sure and get the more advanced testing. But in general, I would say for the vast majority of those women, they're going to be fine and not have to worry about heart disease.
Okay, great. So now we have someone like myself who does have heart disease in two generations on both sides, and my genetics are not ideal as well. So for someone like me, looking at an advanced or more comprehensive lipid panel is super important. So talk about that LP little a for someone in terms of me, and what does that mean? Actually, you know what? I might bring up my blood work, my Boston Heart,
Okay.
so people can see that. So if you're listening, I would jump on over to my YouTube channel so that you can see this. So this is from Boston Heart, which is a really well-known lab, and they
Right.
do very comprehensive, looking at comprehensive biomarkers. And we're going to break down some of this, not all of it. We're not going to get into the weeds. But here at the bottom, so at the top is the standard lipid panel, and then the middle section, here's where our LP little a is. So talk about that.
Yes, your LP is great, less than 15, which is perfect. I mean, there is some evidence that really low LP can be a risk factor for diabetes, but that's pretty weak association. So I think that's really good to have LP less than 15. So you're good there. And so when you look at your profile, the more advanced lipid testing, you see the high LDL 135, the high HDL 82, and ApoB, which is the more accurate risk predictor, 102. But you also have more small dense LDL, which is unusual for a thin woman like yourself. So this could be a genetic factor here as well that we could talk about.
Yep.
Uh, and then when we look at your HDL mapping, we can look at HDL functionality. There is some impairment there. So you do have some impairment in maturing HDL effectively, and looks like you're hyperabsorber. So we get all that is important information that we can apply. It's actionable for what we can
Yep.
do.
Talk
to.
about what ApoB is, though. What does this mean? Why is this an important biomarker?
So ApoB is the amount, it's a more of a measurement of particles. So we typically measure, like LDL here is milligrams per deciliter, weight per volume, milligrams weight, deciliter volume. So weight per volume of cholesterol. But what's more accurate is ApoB, which is measuring the number of particles per volume, protein per volume. And so every LDL particle has one ApoB. And so when you have a lot of LDL particles, you tend to have a higher than expected ApoB. Now, in your case, your ApoB and your LDL are in sync with each other. So there's no what we call discordance. That's okay. That's good. You don't want it to be discordant. You want, in other words, your LDL is 135, your ApoB is 102. That's what you'd expect for 135 LDL. So you don't have a lot more particles than expected based on this analysis. So your ApoB is elevated, but it's also your LDL is also elevated. What you worry about is an LDL that's not as elevated as you think, but ApoB is actually quite high. That's not a good combination. They have an LDL that's not elevated and an ApoB that is very elevated. That means a lot of small particles. So, what happens is when you have discordance, in other words, when one is high and one is low and the other is high, the risk goes with what the ApoB tells you. So ApoB does tell you a better risk predictor. If
And
they're both
this is something you really need to ask for. It's not going to come in a standard panel.
no, and we can have ApoB or you can have LDL particles, NMR LDL particles. They tell you the same
Yeah.
piece of information. So I think you often see LDL particles at Quest or LabCorp, which are more
Yeah.
common than Boston Heart Lab. But what's important is what's called, like I said, is discordance. When you have one out of line with the other, and when you have discordance, whatever the ApoB is tells you the risk for yourself. ApoB is the predominant risk predictor over LDL.
So far in looking at this, would you think something genetic is going on behind the scenes? Because I am a very healthy person. I've been living a healthy lifestyle for 40 years, a really long time.
Yeah, so that definitely, I mean, LDL's high, not sky high. Your HDL is good, but you can see when you actually look at the mapping of it, it doesn't look as protective as you think it should be. So that's how I would look at it as some dysfunction on the HDL side. That's why you can't always go by a high HDL being protective. In your case, it's
Mhm.
probably not protective or may not be as protective as you think.
Right. And I'm at an 82, well over the 60.
Right. You would think that's
Right.
a great HDL, but you can see
Yeah.
by the actual functionality assessment, it's not working like it. You want to see basically it's a garbage truck that picks up garbage. You want to see it keep getting bigger and bigger and bigger. And so in your case, it kind of doesn't quite get as big as it should be in that middle stage there,
Hmm.
the alpha 2 HDL.
Yep. And so I think this is really interesting, the Boston Heart cholesterol balance test. And I want to talk about this because most of the women I work with have never heard of this. And when I send them to their doctors, because I can tell through their health history form that there is a family history, right? Or I can look at their standard lipid panel and see if there's any signs of risk there. So I'll educate them on what the Boston Heart Cholesterol Balance Test is, and we talk about it so they're more equipped to go in and have that conversation. But break this down for us because I found this out about myself over 10 years ago and started on a medicine for it, which we're going to talk about different medicines too.
Right. Yeah, so the lasterol and demesterol are both synthetic markers. So you have increased cholesterol synthesis, which may explain the high LDL, but also you're hyperabsorber of cholesterol. You take beta-sitosterol as a plant sterol that is typically not well absorbed. Very little gets absorbed. But when when you're hyperabsorber of cholesterol, you also hyperabsorb these plant sterols called beta-sitosterols. They're very rare genetic disorder in which you super absorb it and you get premature heart disease, not from cholesterol, but from beta-sitosterol, basically. So it can cause premature heart disease, but this is not what you have, but it can be the case.
Yep. So
Which
when
brings up
you're,
one interesting side comment.
yep.
Shrimp is thought to have a lot of cholesterol. It turns out it's not cholesterol. It's called brasketrol, which is a non-absorbable sterol. So people were avoiding shrimp many years, for many years. We thought it was a high cholesterol food, but it turns out it's a non-absorbable sterol. So shrimp is actually a good food to eat on a low cholesterol, low fat diet. That's one of
I
the
love that you just said that because my mother and I have this discussion and it's a debate every time. I love shrimp and eat a lot of it. She will not touch it, right? And so back to the overproducer. When you're an overproducer, does this mean because all of our cells in our body can make the amount of cholesterol that our body needs, and we're going to talk about cholesterol, right? So does this mean my cells are just making too much cholesterol?
Yeah, I mean, you have the enzyme that overproduces cholesterol. You have just overly active enzymes making cholesterol. That's what it's mostly in the liver, though, primarily, where that's being made.
And
But all cells can do it. The brain,
yep.
every cell can make its own cholesterol, which is important to know because we always talk about getting LDL levels down, very low cholesterol. You worry about what does that mean for cellular cholesterol metabolism, but all the cells can make their own cholesterol anyway. So you don't need it. You don't need it in the blood to get the cholesterol you need for certain things like hormones and things like that. You don't need that blood cholesterol for that reason.
Which brings me to being a hyper absorber. Is this based on dietary cholesterol or based on the cholesterol your body's making, or both?
It's primarily from what your intestinal cells absorb, but most of it is not dietary. It's your biliary. It's also from your bile, your biliary cholesterol. So very little of it is actually dietary cholesterol.
Right.
And,
So
and
I've always read that we absorb it somewhere between 10 and 15% of the dietary cholesterol.
right. Dietary cholesterol has very little impact actually on your blood cholesterol. And that's why, many have advocated that it doesn't really matter about eggs um, all these high cholesterol foods doesn't really impact your cholesterol that much. There are some exceptions, like in your case, because you are a hyperabsorber. I would say that's a different scenario. There are certain genes that make you hyperabsorbers of cholesterol. So for you, based on that analysis, I wouldn't recommend. I wouldn't say you can have eggs. Okay, that's okay. No big deal if you have them a few times a week. But you're not the kind of person that should have 2 or 3 eggs a day. That kind of thing based on that analysis. That's how I would look at it. But for most people, it's not a problem to have eggs, and it doesn't matter whether they take egg or egg yolks. Now, some people have this real strong aversion to any egg yolk whatsoever for cholesterol reasons. That doesn't have to be the case for most individuals.
That is excellent because so many women struggle with getting in enough protein and those healthy fats, and eggs are such an easy and inexpensive way for women to amp up their dietary protein. So let's talk about medications to help someone. There are so many functional medicine MDs out there who are so anti taking medicine, um, especially anti-statins. And, I certainly felt confused about statins myself. For the listeners, that blood work was taken in 2023. I have since gone on a low dose statin of 5 milligrams a day, and I have had blood work, and all of my numbers have completely improved, like drastically improved, which is really important. I have 5 kids. I know my why. My why for longevity is to be there for my kids who are going to have a ton of, I have 5, you're one of 6, I have 5. They're going to have a lot of grandkids. So I want to be around. I want to have an active life. I want to age really well. So that's my why. So I made the decision and my numbers fell into place, which was great that my body had such a positive response to the medication. But let's talk about statins because in the functional medicine world, that is just a no-no, just never go on a statin. But as you can see, there are these huge genetic components to think about and
Right,
acknowledge.
right. Statins, I'm really listen, I'm always open for people what their preferences are, and I try to work with if people don't want to take a stat, try to explain to them, why they're making that decision. But to be honest, I mean, statins have probably the most research of any drug ever when it comes to anything in medicine. We thousands and hundreds of thousands of people. These are very safe medications, and they're generally very well tolerated. So I think people should not be afraid to use statins. Now we could obviously want to use the lower the doses, the better, to minimize any side effects. But they're generally very safe medicines, and have proven benefits in reducing heart disease. I'll just tell you one story from my own personal experience. So my father died, I mentioned, at 47. I was 16. My brother was 14. We both had our cholesterols tested because of the premature heart disease. We both had horrible lipid profiles. I was a skinny 16-year-old. He was a skinny 14-year-old. So fast forward, I've been doing research at medical school. My brother also went to medical school, became a family doctor. He decided to become a vegetarian in his early 20s. I decided to take a statin in my early 20s, because did the research on it. Not early 20s, late 20s. It was late 20s when I started taking a statin, and I was always very cognizant of taking the statin. And then fast forward to age 44, my brother, vegetarian, develops very severe coronary disease and needs a bypass at age 44. Now he's on a statin. He's doing much better. I now in my 60s have had CT angios every 5 years, and I have no coronary disease. And I just think that starting the statin young in life was all the difference in the world between having premature heart disease and not. So I think starting statins young in life, and I think the earlier the better, as far as very strong family history situations are concerned, to prevent heart disease. Now we have so much safety data on statins. Remember, statins came out in 1987, and it's been tracked ever since then. It's millions and millions of people, a lot of research on long-term side effects, and nothing really has come up meaningfully about statins that have concerned. The only thing I would say is there is a little bit increased risk of diabetes with statins, but it's a very low risk. But the reduction of mortality is well present still, and there are your rare circumstances where you get more liver enzyme elevations and muscle enzyme elevations, but those are dose related. And so by giving a low dose statin, you can really get both the safety and the efficacy for most people that you need, to maximize the risk benefit ratio that you have. But I would say that the statins are great drugs, and you want to start them as early as life as possible to reduce risk is a clear recommendation. With that said, I mean, there are other ways to lower LDL for those that don't want to take a statin, that we can talk about.
Yeah, please.
Okay, so I think one thing for those that do want natural products, there is red yeast rice, which is it's not a statin. Everyone thinks it's got a statin. It used to be spiked with statins in the early days, but now they don't do that anymore. It's truly a natural product. It comes out off plants, yeast in India, and it's safe and low dose. It's really a low dose medicine, and that can be an option. We do use that often for those that can't tolerate statins. People also talk about berberine, which is a Chinese herb, and the data on that is relatively mixed, but I have tried it, and sometimes it does work. Also, plant sterols and stanols. These are dietary supplements. You can get them as gummies or pills, and they work by blocking cholesterol absorption. Those are all natural products. So there's what's called the portfolio diet, which is basically soluble fiber. I did the first work on oatmeal, oat bran, lowering cholesterol back in the 90s. That was one of my most famous studies way back when. So oat bran, soy protein, plant sterols and stanols, those three things together can lower your LDL in the 25 to 30% range. It's called the portfolio diet. And so that's an option for people who don't want to take any medicines whatsoever. So it's a lot of oatmeal, oat bran. It's a lot of,
Yeah, but at the same time, oatmeal can also spike someone's blood glucose levels, especially someone like me. I've been pre-diabetic for 15 years. I have half a thyroid for the last 25 years. So even though I am lean and fit, I still face these blood glucose spikes.
Yeah, I know, oatmeal, oat bran is it's a carb, it's a carb like
Yeah.
anything else, and you got to be careful. But I think that's one option to
Yep.
consider. The other is ezetimibe, Zetia, which is a cholesterol absorption inhibitor.
Which
Very,
I've been taking for 10 years.
yeah, very safe drug because you have
Yep.
the hyperabsorption
Yep.
profile. But for those that need a medicine, it's just, again, very safe, effective, not very modest benefit, only 15 to 20% LDL lowering. But I use it also, and often I take it myself in combination with my statin. They work very well together, the two drugs together. And then there are other drugs, but we don't, they're older drugs like niacin and cholestyramine, bile acid resins. People think about niacin being natural, but it really isn't. I was on I did all the research on niacin in the years past, and it does work. It is a vitamin per se. But we're giving pharmaceutical doses, which has side effects. It has especially liver toxicity. I've seen some of the worst liver toxicity among people taking high dose niacin. You got to be careful with it. You got to be careful not to overdose niacin, especially the sustained release niacins. Unless you use safe versions of that, you can get liver issues. And so, but generally, I would say I would avoid niacin as a self-administered dietary supplement type approach for lowering cholesterol.
Yeah, I tried that many, many years ago. My functional medicine doctor had me try that, and I had that flush, and that was the end of that. I tried
Yeah,
it once and never went back.
right. I took it for 10 years before there was
Oh,
stat.
oh
So
my goodness. Yeah.
yeah.
Let's talk about some other additional testing, like a CAC scan or genomic testing. I know we're coming to a close pretty soon here, but should midlife women and men, for that sake, get a CAC scan? What is a CAC scan, and should we be doing it?
Yeah, so it's a coronary calcium score. It is one of the most valuable tests if you're at the right age. I mean, for people below 40, it has very little value because you should be zero, and we don't recommend it below 40. And really, for women, it should be 50. Any woman below 50, it's really not always that helpful. But if you have any calcium plaque, it's calcium is plaque, and when plaque heals, it becomes calcified. Calcified plaque itself is not what you worry about. It's the underlying plaque that gets calcified. So when you have a lot of high calcium in your arteries, you have a lot of plaque in general. The association is there. It's one of our best tests for determining whether someone should be on a statin or not. So if someone comes to see us and their LDL is high and they want to know whether they want to start a statin. We can say, go ahead and start a statin. It's safe and so forth. That's fine. But most people want confirmation that they really need it, which
Yeah.
I understand. And so in that situation, we go through a lot of other factors, including family history, other risk factors, and so forth. CRP, an inflammatory marker, very important for women in particular. If a woman does have evidence of inflammation, then taking a statin for lowering their LDL is even more advisable. But the best test is the coronary calcium scan. It's relatively inexpensive. It's $150, non-invasive. It's relatively low radiation, and it can pick up plaque, and any calcium at all should be a strong indicator that you should be on cholesterol lowering therapy. The higher the score, the greater the plaque, and the younger the age you have plaque, the higher the risk in general. So you want to really use the score in conjunction with all the other factors as well. Anyway, but
Yeah.
I think it's one of the best ways to give somebody the confidence or the confirmatory reason that they should be on a statin.
Yeah. Although when I took the CAC scan test a few years ago, my score was a 0, which, by the way, if you aren't familiar with the scoring, 0 is optimal. It's the best, right?
Right.
You don't want to be up from 0, but obviously so many people could be in the hundreds, they could be in the 60 range, 80 range. I mean, everyone's different. So again, looking at all of these confounding factors, all of your family history, your genetics, and making that decision for yourself is so important. But getting the right information in order to get to that decision is what you have to have.
Right.
So, Dr. Davidson, one last question for you. Is there an optimal heart healthy diet, and what is it?
Yes, I think I'm going to hedge on that because there's not a right diet for everyone. I mean, that's the thing. And so
Yeah.
I would say that if you're prone to metabolic syndrome, diabetes, yeah, we tend to push lower carb, kind of Mediterranean diet approaches. Um, that seems to work the best. If you have, a very high LDL and you're thin, we do push the lower saturated fat diets, in that situation. So, but I would say one thing, that diet is very important. No, I don't want to downplay it. It's extremely important, but genetics are actually a lot more a factor than people realize. And I that's one of the things I try to explain to patients is that they say they eat everything. They don't touch any piece of meat, or they don't have any eggs, and my cholesterol is still too high. What am I doing wrong? Diet's important, but it's only one aspect of the overall reasons why their LDL levels are high. So there are certainly dietary things to do, but I would say don't get discouraged if whatever you do dietary wise doesn't seem to be effective. That's one message I'd like to leave you with as well, because genetics are there. We do start doing that more often now, and I think what the future will be, we can, I think, soon, because we're already doing it right now, but it'll be more widely available. We can maybe tailor dietary advice, based on what the genetics, like in your situation,
Yeah.
you're absorber, you're thin, you do have prediabetes, so you should be careful about carbohydrates. We can do that from the genetic testing. We can find out what genetic factors you have that predispose you to diabetes and why you might be more carb sensitive than others. So I think that's the future, really, is to using what's called nutrigenomics to
Hmm.
understand, why you respond to foods in a certain way while others can easily do it. Like the keto diet, the carnivore diet, for some people might be okay, which we never recommend it, by the way. We don't recommend it because we don't know the long-term effects of these
Right.
very high fat diets. But we don't stop people if they really are dedicated to do it. But we have found many examples, though, where the keto carnivore diet has led to severe elevations of LDL cholesterol, and that is harmful. We have found some genetic factors responsible for that, and so I would say that in general, Mediterranean is what people talk about as being, the healthiest diet of whole grains and fruits and vegetables and lower carbohydrate content, lean protein sources. Those are all, very healthy. Very, very low fat vegan diets are extremely healthy also. So there's a spectrum of healthy diets, I would say.
Yeah.
You,
Yeah.
you don't have to be on a vegan diet to be the most healthy. I think,
Right. And also people on a vegan diet, they need to be aware that they have to do it in a specific way so that they are getting a lot of nutrients and they're going to require certain supplementation that they're
right,
not,
right.
certain
Yeah,
nutrients they're not getting from animal protein.
I've seen examples of vegan diets where it's really been exacerbating the metabolic syndrome
Yeah.
uh, type of parameters that we look at for risk, which are, we mentioned the high triglyceride, low HDL,
Yeah.
which can be detrimental. So I guess the bottom line, though, is diet needs to be tailored as well. What people's preferences are, what their food choices are, and try to find a diet that they enjoy,
Yeah.
and that is healthy. That's really the bottom line
And
for
that's where health coaches come in. We can help people stay accountable and make things easier for them and create that plan with small steps that are going to help them reach that bigger, greater health vision that they have. I love that you're talking about individualizing someone's diet. I look at genetics, and one of the panels I look at is called Diet and Lifestyle, and it can tell me about gluten and dairy and if there's histamines and other environmental contributing factors. And so I really love that you also look at genetics, very different genetics than I look at, which I also did with you, which were super eye-opening. And I'm going to have you come back on so we can just dive into genetics.
Okay, sure. Happy to,
Yeah.
Bill. No, thank you very much. It's been a joy, really, to talk to you about
Oh,
all.
thank you so much. So appreciative of your time. And I know there's a lot of women out there feeling a lot better and um, just taking a nice deep breath and being able to sort through this information will be so helpful on their health journey. So thank you, Dr. Davidson.
you, Jill. Really, really enjoyed it very much.
Thank you. And thanks for tuning in, everyone. Thank you for joining me. I hope you enjoyed the podcast. Lifestyle changes can be hard and overwhelming to make. By building your support team of functional medicine doctors, therapists, and health coaches, you can reach your optimal health goals. Be sure to check out my other podcasts. Until we meet again, stay healthy.